Right, well, it's 2 minutes past, so we shall make a start, I think, and I guess people will be joining us as they come in. So, welcome everybody. Last session of the program. This is really very much around as we hand over now the work that we've been doing so far over the last few months into a period now where it becomes more. And I think we're going to be the theme of the day will be around sustainable change, but about it becomes your work now, and how you take it forward, and really you just got going. I would suggest at this stage, and you'll take all the learning. So this is us not really closing down the program, but we're more so handing over to you guys. So theme of today, just moving forward onto the agenda, we've got hopefully we've got everybody on the call. We'll be doing the poster presentations through through the morning. We've got hopefully we've got everybody from here. We've got Medway, Worcester, Blackpool, Sheffield, Barnsley, and Wolverhampton. Anybody missing? We'll come to that in a moment. But yeah, hopefully everybody's here for that. So we'll run through those post presentations. What we are going to do is we're going to ask you to share your own slides, if you will, if you've got them available. If you haven't got them at hand, we have got a copy here, but we would encourage you to share your own slides and talk through them at your own pace rather than do that usual next slide, please, which kind of breaks up some of the nice flow. Matt's going to come back and do a bit of a conversation on evaluation. We want to understand what you've felt was helpful, what you felt wasn't helpful in terms of this program, so we can get better. We are on a learning journey ourselves, and we always want to improve as improvers. So it'd be really helpful to get your thoughts and reflections back on that. I'm then going to come back and do a short session on sustainable change and sustaining improvement, just to maybe give you a few helpful hints and tips moving forward about how you can take the work and the learning that you've done and then moving that forward. We should be closing 11:45, 12 o'clock. That is the aim. We may finish a little bit earlier, but we'll see how we get on. Next slide, please, Alison. So a few of the usual expectations, please. Going to go through all of them. We've been through this every time, but I think that usual kind of cameras on where possible. Use mute while others are speaking. There'll be an opportunity to ask questions at the end of each presentation. So please, if you want to ask questions respectfully of the presenters, then please do so. Pop them in the chat or pop your hands up at the end, and I'll pick those up. We will keep to time, and we'll encourage people to move into that open-minded, um, a curious space where other people's thoughts and ideas may be different to your thoughts and ideas for your own particular organization. One thing I'm very conscious of with improvement and change is that there are always very much a local element to change. You can't just drag and drop. So what may be right for one organization may not necessarily be right for another. So you may get a different flavor of the kind of themes that are coming out from each organization. Thank you, Alison. So moving on to we what we want to do for this next session, just a really quickly, we want to use Menti again, just to. I think Crystal's going to bring up the Menti screen for us. It's a really just simple question. I think just before we sort of launch into the presentations, if we can quickly log on to Menti, I've just got one question I want to ask you all, just to give a bit of thought in terms of what is that one key piece of learning that you've taken away from this program. So if you can scan the barcode, the QR code there, you can log on to the website using the code 63204023. Give you a couple of seconds to do that. Crystal, if we can move on to we can just start to see who's logging on. Great. So just pop back again to the previous slide. That would be great. So we got the thank you. Just want to see the numbers coming through. So a couple of minutes just to do this, if you don't mind. Great, we all logging on, all fine. So moving on to the results section. Okay, great, got some coming in. Brilliant, teamwork working, streamlining. focus time. It's really important giving people that time and space to think. And when you're in the cycle of the day job, it's hard to think about improvement. Good at galvanizing people, learning from others in the same situation, helpful. That's really good. Thank you very much. Good practice out there. Others willing to share. I think there's been some really helpful conversations, I think, through this program. I've been fascinated sitting here listening to, and some of the curious questions that you've been putting to people as well. And I've been really impressed by the level of respect and honesty that has been shared amongst both presenters and people asking questions. There's been a good level of discussion and debate. I thought was really positive and respectful. Any others? We'll keep this open for a short time and then allow you to contribute this through the session. And we'll again just take this away later and we may just flash this back up again towards the end of the session if we have time. Thank you, Crystal. I think we're going to go back to Alison. Alison's going to share the screen again. Brilliant. Right. So now it's really over to you guys. You've done all the work through this program in between the sessions. Hopefully we've been able to helpfully provide a little space in between that work to give you a little bit of time for reflection and thought. This is the order we're going to go in. So we're going to go with Medway first if they're here, Worcester, then Blackpool. So get yourselves ready and lined up. Sheffield, Barnsley, and then Wolverhampton to bring us up last but by no means least. So if we can go to Medway first. Have we got anybody from Medway? Show hands up. Anybody here from Medway?
I was just looking in the chat, Nick, and it doesn't appear to be anybody from Medway on the call yet.
Oh,
There
okay.
is
Hi, I'm one of the colorectal CNSs at Medway, but I've not been to any of these sessions, so I'm not sure what's happening. And I would have assumed our coordinator team would be here with something, but they are not. Let me nip round. Their office is just around the corner. I think Suzanne Bodkin normally comes to these, so let me just go and see what's happening. So give me a minute.
Thanks,
Thank you.
Amy. Looks like it's gonna go. Oh, Worcester here. So it feels like a Eurovision song contest.
Yep,
Is
Worcester's here.
Worcester? Are you happy to lead us in?
Yep, that's fine. So
Brilliant.
I'm Laura Throssell and I'm joined by Mr. McCarr and Dr. Kurek, I think, from Worcester. I'll just share my slide. Mr. McCarr, do you want me to talk through the slide and then I'm sure you'll have many more comments to add? Is that okay?
Yeah, please do.
Yep.
Thank you,
Okay,
Laura.
one moment. If my screen will share, bear with me a moment. Okay, I'm hoping the screen's changed for you now.
Yeah, it has.
Yes, yeah. Brilliant.
Okay.
Fabulous. Thanks, Laura.
So our focus for the improvement programme was our urology MDT. Our core MDT members are a very committed and engaged team and were part of all of this process. So for some background, our urology MDT runs on a Friday afternoon. Our numbers on the agenda have increased year on year, and currently they are between 80, 100, and sometimes more than 100 patient discussions in that MDT section. This leads to regular overruns of the MDT, which goes out of hours then into the Friday evening and is not ideal. We do have our agenda structured at the moment to aid quality discussion, but with that volume of patients, we felt there's limited options to streamline with the appropriate headspace needed to do so. So the team came together to look at the priorities of the improvement programme and what we should focus on. And unanimously, it was looking at extension of the MDT running time, a relook at the agenda structure, outcome processes from MDT. We've evolved into 3 methods of outcome processes, and we wanted to look at getting that down to 1. and the review of referral processes into MDT. So the method was to develop a proposal for a new extended MDT agenda, and you can see that in the middle of the screen there. Now, for obvious eyes, you're going to see that in streamlining, it looks like we've gone from a proposed afternoon MDT to a whole MDT day. That's not actually the case. We wanted to list all the structures involved in MDT discussion, so as they're visible, and look at who needs to attend which section. So not all core MDT members are required all day, but when are they required? And that obviously encompasses the best use of their time. We wanted to introduce a pre-MDT section, which we don't have currently at the moment, to look at cases that aren't ready for MDT, don't need discussion, or where we can implement some of the standards of care. And also we wanted a visible post-MDT outcome section at the end. I think this is important because, like we said, we regularly overrun into out of hours on a Friday. So a lot of that MDT outcome work, especially for the cancer team, is picked up on a Monday. So we're already eating into the next week. So our lessons learned then, the focus was on allowing time saving where possible. Streamlining the MDT, you can see we've got a lot more sections there for areas of specialism or subtypes. So improving the quality of the meeting whilst maintaining coracy. And obviously some of our considerations there are cost implications or impact or reduction of clinical or lost clinical time. So that's quite a lot to achieve in a short time. So where are we now? We currently have a SOP agreed in place for referrals into MDT, not just for urology, but across all tumour sites. We've got a side separate project looking at the MDT outcome processes and have an electronic version currently in a test. And we've got ongoing discussions through the trust now at a very high level about looking at our proposed new MDT agenda structure, as well as looking at our setting of where we hold the MDT. Our trust has 3 hospital sites, 2 main ones where urology goes ahead. So we're looking at the setting at our Alex site to continue with a high quality hybrid MDT of face-to-face and people joining remotely. So in a nutshell, and you can see the picture there, mugshot of some of our MDT members, so you can put names to faces. It's a bit of a whistle-stop tour. Mr. McCarr, did you want to come in with any further information?
I think it's, thank you very much for concisely putting things together for us. It was opportune for us to join this process, so we're grateful for allowing us to see other services and what they might be thinking of. And what was striking is the commonality of the problems everywhere. In a nutshell, is a huge and increasing workload for urological cancer for various reasons. We're not going to go into them now, but it seems that the numbers, we've been looking at the numbers of 2-week referral and the numbers of diagnosis of cancer, and just to state a fact, we have only about 60% of our cancers diagnosed via the 2-week referral pathway. Quite a lot of them are still coming through other pathways. And the workload is going in one direction exponentially, more so than what we would have accounted for by the demographic change in our region. And we think this might be some effects from the pandemic and what it did to the delayed referrals and increased public awareness, which is a good thing, of early signs and symptoms and quasi screening. There is a conflict here between high quality MDT with meaningful discussions and productivity of the team in terms of actually doing the work. And that conflict is not going to go away, and I suspect it's available everywhere. There was a problem that we always had, which is the old style peer review, which mandated that any core MDT member should attend a minimum of 2/3 of the meeting. Now, if you calculate that, it means that most MDT members will have to attend every meeting unless they are away or off sick or annual leave or whatever. And that will impact the productivity severely. Going round the country and looking and benefiting from this exercise, but also before this exercise started visiting other units, it's become very obvious that it's very acceptable now to compartmentalize the MDT into tumor sites within the urology MDT, and that not every core member needs to attend every section. So if an oncologist is only doing kidney cancer, there is no point in him or her attending the prostate section or the bladder section. And that was why we came up with this division of the MDT into smaller MDTs, although in our case they will all happen on the same day for logistical purposes, not least because we work from different sites. Anyway, so that's the main change that is being proposed to introduce to allow the people who need to be in the discussions around certain tumor site to be available, but then they don't have to stay for the rest of the sections of the MDT. They can go and do a clinical operate. The other one which we are still struggling with is the streamlining. I'm assuming everybody is struggling with streamlining because if you don't discuss certain patients because they don't have a diagnosis of cancer or have a diagnosis of the so-called regular standard case, there is nothing regular or standard about cancer or our patients. Every patient is unique, and we discover loads and loads of patients who benefit from discussion when you start off thinking they are regular standard case, but once you start to discuss their MRI scan or their histology peculiarities, you discover they are very special and they might need some nuanced decision making. The last thing I would say is we need to go back to the good old standards belief and understanding that MDTs are very helpful, but the decisions or the opinion of the MDT is not binding and does not replace good doctoring and good clinician, because the patient is not in the MDT and you don't know what the patient's wishes are and what the patient's beliefs are and what the patient's priorities are until you've actually met him. So I think we are going to adopt a disclaimer at the bottom of every or the top of every MDT outcome form to say, this is a consensus opinion. It is an opinion of the people attending the MDT on this day based on the information available to them on this day in the absence of patient. Because I've seen over the years huge medical legal problems if the clinician dared to deviate from the letter of what is recorded in the MDT, and the lawyers come down on you as a ton of bricks. So it's very important to remind everybody that this is a process to help the clinician and the patient in their decision-making process, but it does not replace it. They still have autonomy, they still have the clinical responsibilities and duties to the patient, and I'll stop at that. Happy to take questions.
Thank you all. Thank you, Laura, for sharing, and Dr. McCarr, Mr. McCarr, thank you very much. So any questions for the team from Worcester? Dawn?
It's not a question really, it's just some feedback. I think the statement that Mr. McCarr's just made about the statement or point that goes out on every MDT, that this is a consensus and opinion and doesn't supersede your clinical judgment, was a conversation that we've had in the office this morning. So we may be pinching that one from you if that's okay, because there is a tendency now to defer to MDT decision and think that should supersedes your clinical opinion when that shouldn't necessarily have been the case. So thank you very much for echoing a conversation that we had in the office this morning. It gives us a little bit more emphasis to change what we're doing. So thank you for that.
Thank you, Dawn. Really helpful. Mark.
Hi, so just unmuted. Hopefully you can hear me. So I'd just like to add to that point, because I don't believe that's necessarily true. And part of the MDT processes is to have a consensus and give a recommendation. And part of it is to improve patient safety. And we only have to look at the recent cases in breast surgery in the Midlands to understand that there are outliers in every medical specialty practice. And part of the MDT process is to guide process and avoid clinicians who might ignore the MDT process. So we have to be mindful of that.
Thank you, Mark. Yeah, good reflection back. I think that, I think also the thing I picked up from this presentation is this balance. There's always a balance, I guess. There's that sort of Goldilocks position where it's neither one nor the other. There's often a period in the middle when we talk about also about streamlining and time taken to get into the discussion. So I think there's always a bit of a balance in that. So it's finding that sweet spot in the middle, I guess. Any other questions from us before we move on? Thank you, guys. Really helpful. Thanks for getting us started. That's a really nice one to kick us off with. We're going to move through the list. We've got Blackpool with us today.
Yes, we have one here. Yes.
Fabulous. Can I hand over to you guys?
Thank you very much. Okay, so good morning, everybody. My name is Jawad Islam. I'm the urologist at Blackpool. Thank you very much for providing the opportunity to discuss the issues of our urology MDT at Blackpool Teaching Hospital. Our main issue has been the numbers. The numbers in the MDT has been around 50, but the problem here is that we have got only 2 hours for the MDT. We have got a wonderful team, oncologists, pathologists, and radiologists, but the amount allocated to us, it becomes very challenging to present all those 50 cases. And we have done a lot of work on our MDT previously, but the numbers have not come down. And we looked into that why the numbers are so high. Firstly, we cater a large population. Secondly, Blackpool is a deprived area with a lot of health issues and a lot of comorbidities, and probably the highest rate of upper tract TCC in the country, probably because of the very high smoking rate. And nationally, we have seen in our recent prostate cancer audit that the new diagnosis of prostate cancer have significantly increased. So looking into all this, we have a few years ago, another 2 years ago, we did a piece of work on our MDT, and we introduced a couple of things. For example, we did a sort of a pre-meeting workup that every consultant looks into the MDT list before it is finalized, 24 hours before it's finalized, in order to remove the patients which do not need to be discussed, or if they want to add anything else in the MDT. We also introduced some standards of care, and in spite of that, the numbers have not come down. And if you see here that we looked at the numbers gathered in last 1 year, and it hovers around 45 to 50. And we did a gap analysis looking into all these things. There has been an improvement, but obviously they had a lot of work to be done yet. One of the biggest issue was we got two wonderful uroradiologists, and when one of the uroradiologists was on leave or on sick leave, the other uroradiologist was not able to go through all the cases. So after a lot of discussion, the trust agreed to give us a third part-time uroradiologist in case one of them is not here. So that has improved the things a lot in recent days. But looking at what else we can achieve, and looking at the presentations in this forum, we established an MDT improvement working group to explore the other things. And what we have come down is that there may be some patients that can be omitted from the urology MDT, particularly looking at the recurrent superficial bladder TCC, which do not need a change of treatment. Number two, particularly the Bosniak 2F renal cysts, which are being followed up for quite a long time, and they come with the CT scans every 6 to 9 monthly, and they're put on the MDT. They're quite a chunk of patients. And we suggested that if our uroradiologist can report these scans, and if there's no change in the size and the character, then don't need to come to the MDT. And we also suggested that the incomplete staging of the tumors should not be put on the MDT, although there was a bit of controversy on that this will delay the discussion, and they will not be achieving the target dates. But I think this was one of the things that we put in place, that those patients who are not completely staged should not be discussed in the MDT. And lastly, I think we're thankful to our to some of your team that they've asked that they can provide some training to our MDT coordinator, and we have seen that the MDT coordinator is one of the most important person in the whole MDT. Thank you very much.
Excellent. Thank you very much for that. Really, really helpful. Any questions for Blackpool? Alison.
So can I just ask, the working group, is that something you're going to keep going moving forward, and where do you think, how more can you use that to sort of help drive some of the changes?
What we suggested that between urologists, radiologists, pathologists, and some of the management, we need to discuss these issues again and again, how we can improve the thing, particularly this big issue that if some of the scans could be reported by the uroradiologist, obviously they may not need to come down to the MDT. Similarly, there are many other avenues, for example, on patients on active surveillance, which may need repeat MRIs, they may avoid the MDT. So sort of a working group to keep on discussing these issues and what support the management can give in that.
Thank you.
Thanks, Alison. Thanks, Jad. Any other questions for Blackpool? Mr. McCarr.
Yeah, again, it might not be a question, it's a comment, which is to acknowledge that even in Blackpool, when they have half of the number that we have, they still can allocate 2 minutes per patient if they've only got 2 hours, which is bizarre to consider this as a decision-making process that will supersede good clinical judgment after an hour consultation with the patient. This is just to make the point. The other thing is, it's very, very important that this process is an iterative process. Paradigms change, new treatments arise, new investigations arise, and we have to be flexible to accommodate within our MDT structure and discussions and membership, everything to reflect the state of the art as we go along. So it's an ongoing process. It's never ending, and it has to be taken over by the operational annual or 6 monthly meeting for the team to be able to adapt to changes that happen as we go along.
Thank you, Mr. McCart. I think you just pinned some of my slides for later on when I'm going to talk about sustainable improvement, because it's exactly that, how we just treat this as a continuous process. And thank you for that. Any others before we move on? Hopefully, I think we've got Sheffield lined up. Can see faces on the screen. Fabulous. Thank you very much. Can I hand over to yourselves in Sheffield? Thank you.
Yeah. So this is Ahmed and Mukhtar. So my colleague, Mr. Peterson and Mr. Shah, they will also chip in about this MDT improvement. So first of all, we would like to thank you, the organizer, and the people who participate in taking this effort for this MDT improvement. Why we are saying this one, not just as formality, because from someone who was reluctant against participating in this, I found it very useful, and we have done some changes. So the credit to the people who organized it first, okay? Number one. Number two, Mr. McCart touched on it. I can take you through our poster, but this is not the whole learning process. Number one, it's MDT is the end product. It is an evolving things. I don't think that we should just stop by the end of this poster. It is an evolving process which we are going to build on. What's unique here in South Yorkshire, Sheffield area, I feel as the CDG lead that it got us together. So we have a special format here through CDG meeting, which we meet with the whole area. So everyone have a voice. Everyone has participated in MDT improvement, the whole South Yorkshire. We listen to the people. We got together. We start knowing people all. We feel much more better as a team. We're a team together and decision maker than before. So this is the point we want to highlight as well. Not only we improve the streamlining of the MDT, we have improved the process in which data being reflected on a national level. To give you just an example, while we are improving the MDT, we discovered that part of the ticking process, the CNS improvement, and we have improved this one from 18% to above 88% while we are doing the MDT streamlining. So the process is not limited just to the MDT itself. It has improved the whole pathway of patient journey. So why did we improve this one? Similar to my previous speakers, we have a huge number of patients increasing years by years. And we discovered that in 2.5 hours, that 40% of the patient not being discussed. So as a group, we sat together and we started this process with the help of the MDT improvement, and we looked into different pathways, how we are streamlining. We learned from, I have to say, from our colleague in the urology experience, especially in the southwest of England, which it was very good. Like they gave us some hint how to organize this one. And we start to take some more of the patient off the MDT into a different MDT, different format of MDT, IPM and MDT, benign MDT. But as my colleague mentioned, Mr. McCart, I think this is going to be a problem with an increase health education, surveillance. The number will increase more. The modalities of the treatment is increasing more. So the timing for the MDT is always going to be a strain here. And I might put this one to the whole panel. Single MDT, in my opinion, a week might be not enough. Might be 2 MDTs a week might be the way forward. But this is an open discussion with the rest of the team and all the members. So what we have done, we have adopted different pathway. First, we improve the referral pathway on the performer, especially for hepatocellular carcinoma. We reduce the number of the patient. And I think the most achieved things been happen is for my colleague, and Mr. Peterson will come on that, is a pre-MDT preparation. And Mark, you can highlight this point, please, if you don't mind. You are muted.
Okay, yeah, so I mean there's an issue with that. I'm actually doing that while we're doing this meeting, so trying to do some mail multitasking, which doesn't always work, but the triaging can bring the number of cases on the MDT down. The problem we have with the triaging is, I mean, I started that at the end of last year, but it's not part of a job planned activity. So we need to get the trust to recognise that activity, and secondly, have other people who are able and prepared to take that forward, because it's unsustainable for me to carry on doing it. So the problem we have is that there are ideas, but they need to be backed up by management for both, you know, investment in systems and investment in time. The other problem we have is a sort of cultural issue within the department, where the MDT has developed over the years to be a backup for results and keeping track of patients, which is not the best use of time for the MDT. And I would say there is, let's call it, resistance from some colleagues to not having their patients on the MDT, and instead reading the clear outcomes and reports of radiology themselves in their own admin time, and just making decisions on the patients, which we've had in comments earlier on in this meeting. You know, once there's a pathway for the patient, you don't need to keep rediscussing them on the MDT after every investigation, unless there's a particular problem with that investigation that's highlighted on the report. So there are things to iron out there. I mean, we were at the start of this process, we'd already started to put some stuff in place, and we'd had a GIRFT meeting with the national team from GIRFT, so we already had a fair amount of fair idea of what changes might need to be in place. I think having more cancer trackers to chase up the reports and track the patients is important, in not having patients repeatedly needing to be on the MDT. In terms of the splitting of the workload into different parts of the week, that's always going to be a difficult task, especially when you haven't got high numbers of clinicians attending the MDT, because people don't have time in their job plans necessarily to get back together and discuss the same kind of cases. So we had thought about splitting off our HCC section, but that requires the same oncologists who are treating the other diseases and the same vascular radiologists. So it's difficult to get time within everyone's working week to have more meetings. I think the other point, I think, is trying to get more engagement from our referring hospitals, and you know, we have, you know, spoken to other units to see how they organize that in terms of technology and timing, and are preparing to have either in-person visits or joining their meetings online to see how they run and see how we might be able to introduce some changes to our MDT. The difficulty with that is the time factor, because those MDTs where they have referring hospitals logging in at a particular time point, unfortunately end up slowing down the MDT. So we would have to significantly reduce the numbers on our MDT to facilitate that happening. I guess, one of the other points we have is the outcomes from the MDT, and we heard before about it not being a fixed outcome and needing clinical input, and that's really important. We haven't yet found an ideal way of documenting the outcome. Currently, we have a contemporaneous screen at the front of the MDT meeting, which everyone can see, and it's also shared with those who are logging in online. And the outcome from the MDT is typed into that by our MDT coordinator, and the person who is presenting the case at that MDT, which is usually a consultant responsible for that patient through the MDT process, has sight of that outcome during the meeting. But still, there's a lot of complaints about the perhaps occasionally confusing MDT outcomes. So we need to get people to, I think, take more responsibility for the outcomes from the MDT. I don't know how other MDTs work in terms of producing the outcomes. Everyone has a slightly different system, and sometimes it's just one person there who is putting the MDT outcomes, possibly a clinician, but that's a lot of work for a person who might not always be present at the MDT. So I'd be interested to hear what the other groups manage with that. So that's probably enough from me, I think.
Yeah. So to summarize it, I think it is an evolving process. And Nick, I think in the future, if you ask us in 1 year's time, again, if you are running this course, I'm happy to come back to see what's future improvement, which we are going to carry on, because this is just a snapshot of what we have done. There is a lot of work in terms of electronic referral system, which we try to introduce and hopefully will be successful for the future. And I think also my colleague, Mr. Shah, want to say something about that. And then from my side of view, I'm happy to answer any question.
Hi, thanks, Ahmed, and congratulations to all the stakeholders who have initiated this program and have successfully seen it went through. Thank you to Tamsin as well, who's our coordinator, who's helped us with everything. So, I mean, there's Ahmed and Mark has alluded most of the stuff which we were having shortcomings and what we have done to introduce. We've tried to implement quite a few changes already. One of the changes, as Ahmed said, there was CNSs and tracking was not there, which you could see in one of those figures, has now been more than 80% and in some cases 90%. And by next year, it should be more than 90%. We've also taken out a lot of cases. We're introducing new IPM and MDT. We have formulated, as Ahmed is also one of the members and chair for the CDG, we have formulated the benign MDT guidelines for IPMN, for adenomas and other cases, which will be circulated around the region so that unnecessary referrals won't happen in our MDT. That is the idea and the aim, and they will be referred more to our benign MDT. So we are offloading quite a bit, so we can spend more time to our complex patients to be discussed in the MDT. And as Mark is already spending quite a lot of time in his MDT prep, and it takes a lot of time, and I've done it while he was away for a while, and it does take a lot of time. So hopefully some more negotiation with the trust, and we should be able to get some more MDT prep time with us as well. So thank you. That's all for me.
Any question for us, please?
Thank you, team. Excellent. Thank you very much for that presentation. Really, really helpful. Any questions for the team at Sheffield? Mr. McCarr.
You're asked to make it interactive, so let's make it. I think I think you've highlighted from Sheffield one of the problems that we all suffer from, which is people are dumping, for wanting of a better word, stuff on the MDT to absolve themselves of clinical responsibility. And the commonest problem that we have is when a radiologist or somebody in A&E or something like that sends you something, a report or something, hey, please discuss in the MDT. Well, in the good old days, when you're not sure how to report this CT, you turn to your colleague and discuss it with it and do your own MDT in your own department and then put a report out. But to think that adding the phrase discussing the MDT, you absorbed yourself from the responsibility to making a good report, we all suffer from it, because dare you or I not discuss it in the MDT, when some other consultant said discuss it in the MDT, you are opening yourself for huge criticism if anything goes wrong. So everybody is practicing in a way that they're covering their backs, and the MDT is suffering from it. And we've got to stop the rot. We've got to give national guidance. You cannot do that. Discuss it with your colleague, and yeah, if it's a unique, complex problem and needs to be discussed in the MDT, that's a different process. But this is a huge issue for all reports coming from GPs, from A&E, from colleagues in radiology and everything else. I don't know what the answer is. And part of the problem is a lot of trusts, because of the workload and the mismatch with manpower, they are outsourcing, and you have no quality control at all on the reports coming from outsourcing. So you can't tell them, oh, don't send the patient to MDT just in case they are not specialized in this area. Any outsourcing project or program needs to have inbuilt in it ongoing quality assurance, and you cannot replace good clinical practice by dumping everything on the MDT.
Thank you, Mr. McCart. Good thoughts, observations. I think picking up on that, picking up on what Ahmed was saying about what we will look like in 12 months. It's thinking about those people we will need to continue to connect with, those stakeholders in this work. So whether it's GPs or whether it's emergency medicine consultants or whoever it might be, in terms of engaging and understanding how MDTs are changing, because it may be possibly maybe based on outdated perceptions of what an MDT might be, particularly as you're progressing, you're improving, and maybe other people are getting slightly left behind in their understanding of what the new MDTs might look like. Thank you for that, guys. Really helpful. Any other questions for Sheffield before we move on to Barnsley? No, is Barnsley with us?
Yes, I'm here, Lung MDT lead. If you just bear with me, because I've been having some technical issues while I just try and share my presentation. I'm not being
No worries. If Ahmed, if you could stop sharing your screen, and then we could jump on Barnsley when we get to it. Fabulous. Thank you. Amazing. Oh, got again. Have we got the slides for?
Yeah, do you want me to try and share? Would that be easier?
Yeah, Alison, if you can jump on that and then give them a chance to talk to the slides. Is that easier for guys at Barnsley?
Yeah, sorry, my apologies that this computer's been a nightmare this morning.
No worries.
Keeps going and off. So sorry about that. Yeah, so I'm Catherine Patrick, and I'm lung cancer nurse specialist and also uniquely the lead for our Barnsley Lung MDT. We looked at, we already have an existing pre-MDT in place to help streamline our MDT, but I'll be perfectly honest, it was more of a get together, chat, refresh memories about which patients were on it, and our numbers for our MDT were increasing dramatically over the last few years, especially with the onset of the lung health check screening programme. Our MDT normally runs on a Tuesday morning from 9 till roughly 10:30, and then we have a clinic straight afterwards. Unfortunately, this was increasing in time and we were constantly running over, and we had to do something about it. So we had a look at our pre-MDT to see how we could streamline things even further and utilise it effectively rather than just a refreshment of memories. So we looked at obviously what patients were allowed onto MDT in the first place at pre-MDT, made sure all referrals were appropriate. Anybody who was on the MDT, added to the MDT, had been reviewed by a respiratory consultant, so we had up-to-date information about the patient, relevant information, and we also looked at ensuring that all investigations were in line with our standards of care and that results were available. All information no information was missing, and if we did want anything specific from a radiology point of view, that were actual direct question to the radiologist, so that would cut down on their prep time. What I found was that some of the difficulties were getting all our respiratory consultants to engage in this process. Unfortunately, I think there's still a little bit of kickback about the fact that I'm the lead for the lung MDT. Yeah, so that did, I think that were quite a negative sometimes to some of the work that we were trying to take forward. Also, some of the consultants were taking cases to the MDT. We've alluded to the fact that sometimes patients are put on MDT rather than clinicians looking for results and acting on them and looking for reports. And we found that there's been a lot of nodule follow-up patients that's been still being added to our MDT, which we're then having to take off at the pre-MDT. Maintaining momentum of keeping our changes going forward has been a little bit difficult at times, depending which members of our respiratory consultants are going to our pre-MDT. Moving forward, we're going to be looking at who actually should be attending the pre-MDT. Do we need every respiratory consultant there, or should it only be the consultants who are actually going to be presenting the cases on the main MDT? We normally sit in pre-MDT on a Friday afternoon, ready for the meeting the Tuesday afterwards. And historically, any clinician that's available from a respiratory consultant point of view goes to the pre-MDT. I would question whether that's a good use of time. Could we just not have the consultants who are actually on the rota for the MDT the following week, just to streamline it even further? We're looking at the quality of referrals into MDT, encouraging electronic referral forms, and just really trying to get better engagement with our respiratory consultants to try and move this further forward. We've done as you can see, we're on average, we can take quite a few patients off at pre-MDT, which helps the process for the main MDT the week after. It's a bit of a whistle stop description of what we've been doing, but
brilliant, Catherine. That's really helpful. Any questions for the team at Barnsley? Tamsin.
Hi, yeah, I think the work Catherine's done is brilliant. Obviously, from a South Yorkshire Alliance perspective, I've met Catherine, and she's kind of spoken about how this approach has developed, and I think it's really positive, but not without its challenges.
Yeah.
I think, and we've tried to sort of pick up and learn from that, I guess, across South Yorkshire, and sort of develop a sort of template of what a good pre-MDT might look like, and we're just sort of drafting that with support from all our providers. And so for those pathways that do want to implement one, that we can kind of sort of suggest what might be good in terms of membership, in terms of efficiencies and time, and how that can be used partly to justify people's job planning where job planning is done for their role. So yeah, I just want to sort of to thank Catherine and all the HPB folk as well, and for the work they've done in this programme and more widely.
Thank you. Thanks very much.
Thanks, Tamsin. Mark?
Yeah, so my mic still on?
Yeah, you're
Yep.
still nice.
Okay, so I mean, one thing I do when you're looking at the possibly pre-MDT review is that probably is going to have to be a virtual review with multiple people involved, maybe, you know, histology coordinator, a designated consultant from the MDT staff, not necessarily the MDT lead, and at least for HPB, probably 1 or 2 radiologists, because of CT and M are involved, and getting them through in a meeting together at the same time, looking at people's working weeks, is just not going to be possible. And certainly within our MDT, most of the prep time from myself and our radiology colleagues is done outside of normal working hours, certainly for the radiologists at some time at the weekend, and actually in our own time on the day prior to the MDT. So, you know, I think a lot of people will struggle to get you know, a formal pre-MDT, so that can be a triaging process, but I don't think realistically it needs to be an actual meeting with the same people at the same time. It just needs to be a group of people feeding back information to the MDT coordinator. And one of the things we have introduced recently is having a live web-based document for the agenda, where there are tracked changes on the form, so the MDT coordinator can see those comments as they come in from the different clinicians, so they all feed back to the MDT coordinator. So I would just highlight that as a really useful way of doing it. We've found it seems to be working really well currently. It's only in its infancy, but it means that, you know, there's fewer emails and correspondence flying around, which can and has led to mistakes with the wrong information being attached to the wrong patient. So it's just another idea going forward.
Thanks, Mark. Helpful feedback for the team at Barnsley to consider.
Yeah,
really useful.
Yeah.
Sorry, Catherine, I spoke over you.
No, it's fine. And yeah, I agree. Trying to get everybody in one room is difficult for all of us with challenges that we're all faced. And radiology is a challenge that we face over in Barnsley. And unfortunately, we don't have radiologists to our pre-MDT. That's why we try and streamline it a little bit, that if we do want their input, that we do a direct question to help them out. We have asked for to attend pre-MDT, but with the constraints of the timetables, it's just totally impossible. But I think that's a fantastic idea about having a central place that we can send questions in and things and get feedback. I think that would cut down on the multiple emails that we all get and potentially could miss because of the number that we get.
Fabulous. Thank you for that. Really helpful. Okay, last but absolutely by no means least, is Wolverhampton on the call.
Hi, Nick. Hi, everyone.
Over to you, sir.
Well, it's hi. It's been quite interesting. I think this journey has been amazing in terms of learning and sharing experiences. And by all means, we've tried our own best, and I've seen the impact of the the improvement program. As a background, I'm Olumide Finron. I'm a gynae oncologist plying my trade in sunny Wolverhampton, and currently the only gynae oncology subspec, but I'm surrounded by a fantastic team of specialists, and we're all here in our numbers, from our oncologists, radiologists, and our clinical nurse specialists, and of course, most importantly, is our MDT coordinator. Our MDT for years as tradition. I was first here 2013, and then came back again at the end of my fellowship. Now, it's used to hold, and I say used to hold, on Monday evening, actually, 4:30 p.m. And as you could tell, 4:30 p.m. lasting 2.5, 3 hours would run till around 7 p.m. And by then, you're probably tired, you just want to get out. And because of clinical commitments, a lot of the actions weren't carried out to probably Tuesday, Wednesday, even Thursday. And so a lot of delays in contacting patients, a lot of delays in treatment, but that's how it's always been. And I think that time was suitable for everyone. When I came on and took over as the MDT lead, it carried on, but I realized that we could do better. So we sent out a survey to everyone asking which time best suit them. And almost everyone, in fact, the only people that said no were those that didn't respond. We're happy with moving it to within working hours. And so we had a 6-week trial from 4:30 p.m. to whenever time we started at around 3 p.m. Oh, yes, you see our facility team there. It's a mixture of face-to-face and virtual. We still prefer both. So, and what we found out was that allowed, apart from more attendance, it was something, there was in fact almost no resistance to the time change. And then in addition to that, I had introduced MDT prepping, so which meant that I was ready, got all the details, and was able to, succinctly discuss these cases at the MDT. One thing that we needed at that time, which we still need, is the pre-MDT triaging. But so what happens is this: MDT holds the Monday afternoon at 3 p.m. The deadline for submission used to be Friday p.m. And our radiologists also found it a bit difficult at the end of Friday prepping for an MDT on Monday afternoon. So we then moved our submission time to Thursday afternoon, which allowed them 48 hours, which was acceptable. But we were also flexible in accepting late additions, especially histologies, up until even then. Just that at the bottom of the list, you had a separate section for late additions. And it's improved things. So what we then found out that, because we're going through my little notes here. So what we found out was that the first thing was that there was more acceptance, there was more attendance. There was a reduction in the case list from about 40 to just under 30. I mean, apart from the fact that being the only Ghanaian oncologist, I had to stop 1 or 2 SLAs with some other trusts. Now, this allowed us more time for discussions. So you now had, with a reduced number of cases, you had more, what I thought was more quality discussions. So we spent more time on those cases that needed discussing. After the MDT, which now ended at around 5, we're able to get everything done within 2 hours. Some of us, so the clinical nurse specialists, the MDT coordinator, myself, would stay back and run through the outcomes about the work and the jobs that needed to be done. We were also able to allocate patients straight away into clinics, which meant that a lot of the patients were now seen either that week or the following week. I also then stayed back, which was good for me. So about 5 to 6 allowed me to stay back and not get into the rush hour traffic. And if I needed to request investigations right there and then, I got them sorted out, and I would even ring a few patients almost immediately. So that really improved things quite significantly. And that's, I think, what's changed. So we now have what I call stronger or better engagement amongst everyone. There's more time savings. You're not drained. You're not tired. There's more consistency. So I think it was the lessons that we learned for this was one, you actually don't need significant changes to actually make a change. The slight amendment of the time from 4:30 to 3 p.m. completely changed how MDT has been or how things are. Now we're looking to move into electronic performers if we can get, once we have more resources. And we're also then looking at the pre-MDT triaging Now, I think Mark mentioned it, and I think Tamsin also talked about it. It is quite difficult to incorporate that into your job plan. How we're going to get through that process, because that way you can actually sieve out a lot of even the unnecessary cases that need to be discussed. So I'm looking forward to actually finding out how we can get that done. I welcome, so for now I'm done speaking, but I welcome any of my other colleagues who are here who want to chime in rather.
Hi, Mike. Thank you so much for that. I'm absolutely in agreement with everything that you've said. I'm one of the radiologists who does the gynae MDT with Mike, and I think we have a lovely team, and we work really well. And I think we have definitely improved things since the beginning of these meetings. So, thank you.
I'm an oncologist, and just to add, yes, I think the change of time was very welcome, and electronic forms would also be welcome for the future to maybe decrease the number of cases. But I think it's working much better now. Thank you.
Thank you, team. Excellent. And just go to show even some of the smallest simple changes can make a big difference. It isn't always about the big stuff. Something as simple as just moving the time and trying that out. Really brilliant. Thank you very much. And clearly a sense of that you mentioned there about Olamide, about a sense of teamwork, bringing people together, having those conversations. This work has sort of moved that forward. So helpful. Sometimes that's as good as anything. Mark, is that a legacy hand or is that a new hand?
Legacy, sorry.
No worries. Thank you very much. I know you're trying to multitask at this point, but yeah, doing it incredibly well, I'd say, Mark. Yeah, even for a bloke. Thank you. Right, cool. Thank you. Any questions for the team at Wolverhampton? Oh, fabulous. Thank you very much. Oh, Matt.
Sorry, latest party. I just wondered, maybe you thought the fact of doing something as a pilot, that helped sort of make it easier to make the change. Because I think sometimes people are a bit nervous. They think, oh, this is the change, it's never going back. Did you find that sort of piloting it was helpful to get people bought in?
Yeah, you're right. I think that was one of the most important things. Very clear from the onset that, listen, we're just trying out various things, and it's over 6 weeks, so it's not set in stone. And I think that allowed us to make adjustments, and everyone was given a voice. You'd be surprised that the suggestion from the MDT coordinator and our clinical nurse specialists were very, very welcome. And yes, at the end, and towards the end of our 6 weeks, I actually declared, say, listen, we've made so many minor adjustments, and it seems like we're going to carry on. So yeah, you're right, Matt. I think that pilot and letting me know that this is not, it was actually very, very important. Yeah.
Good point. Thank you. Mr. McCarr?
Yeah, I think a common theme that came across from all the presentations is the lack of resources. And we've gone through the work. We're going to be doing it regularly. It's an iterative process. But unless we get a buy-in from the purse string holders in the organizations, we're not going to be able to effect the change. And I think it's incumbent upon NHS England or the son of NHS England to make it clear to executives all over the trusts everywhere that although you cannot see the financial benefit of getting it right first time, there is huge financial benefit. Not only the quality of care for the patients will improve, but actually as an organization, if you avoid mistakes, if you avoid unnecessary treatment, if you avoid unnecessary scans and appointments, you are going to get back what you paid in planned activities for these people to do their pre-MDT meeting, or to do 2 MDTs a week, or to do a longer MDT. That needs to be made clear, because unfortunately, and I'm afraid not all of them can see the hidden savings, which you can call it opportunity savings or whatever. This needs to be highlighted to them so they don't stall the good work that everybody is doing.
Thank you. Yeah, good point. I think the thing about resource often is that, which is not something I've heard today, is that sometimes our starting point is we need more stuff, we need more people, we need more something. What you've gone through here is an evidence-based discovery to understand what you actually need, because you've understood it more. And I think that's the value in going through that process, rather than the first point of call thinking the improvement is just throw more people at this particular problem, and that's where, you know, having a more intelligent evidence-based perspective on additional resources is really useful. So the work that you're doing really supports that, and we're really thankful for that as well, because it backs up that you've gone through a process to understand what resources you need, rather than the starting point is we just need more stuff or people or time. So thank you for everybody in that. Good point again, Mr. McCarr. Any other questions? I'm going to go pick up Dawn on her offer of just sharing quickly what Liverpool Women's Hospital has been doing. If you don't mind, Dawn, put you back on the spot a little bit.
Yeah, not a problem. I'll share it. I'm presenting these slides on behalf of somebody else, and we've not used your fancy template, but when it goes on your platform, we shall use your fancy template if you'll allow us to. I'm just hoping I can share. IT is not my strength. Can you see that? Or not?
We can, yeah.
Yeah, okay. As I say, they're not fancy slides by any stretch of the imagination. So just thought give you a summary of where at Liverpool Women's we have been up to. So we are the Regional Cancer Centre for Gynae Cancer within Cheshire and Mersey. Has that moved on? Has it moved on or not? Because I can't see it at all.
Okay. Moving on to slideshow.
Has it moved now? I didn't click hard enough. So our MDT journey so far, I think it's useful to sort of take a look back. In 2020, our Cancer Alliance funded a review of our gynae cancer service back during COVID, which is perhaps the most challenging time to do it. And when we eventually completed that review, there were 63 recommendations on how, as a clinical and operational team, we felt we could improve. And MDT was a key part of that. And from that review, we added in separate timings for cancer units to join us in our main MDT. We discuss on average about 80 patients within a 2-hour window within MDT, and then our clinical team go straight into clinic afterwards. So it's a heck of a day. We re-reviewed it in 2023. We found we were spending between 2 to 3 minutes on each patient, and the MDT was running relatively well. And we introduced lots of different changes in between that as well. We were fortunate enough to have an external review from somebody from NHS England in 2024, which gave us lots of positive feedback about what we'd changed already, and suggested that we took part in this programme to move us on yet further. As a background to that, we've always held a yearly MDT working meeting, face-to-face when we've been able to, looking at processes, experience, and just gelling as a team, because our MDT, like every other one, is, or I'm making an assumption, is a bit hybrid and a bit in the room, which is good, but presents a challenge. But it was lovely to get in the room with people. So this year's review, we focused more on the systematic changes. This makes me laugh because they've asked me to present this, and I'm the most digital unsavvy person within the whole MDT. During COVID, we moved from triaging our MDT referrals from paper-based system to a Microsoft Teams model, which has worked well, but we've actually outgrown that now, and finding lots of issues with communication between that and our EPR, found a lack of standardization, and a whole range of things that as you make an improvement, you realize, okay, maybe doing that better, but we need to move on to this other next thing. Our team has grown as well, fortunate enough to say, from a surgical base, and with more consultants, then people were doing other things on MDT days because there were other challenges within gynae systems. And everybody likes to help out, don't they, and think that somebody else might be at MDT. So that's come up as an issue. So we've got lots of proposed solutions for that. So we are currently looking at a different system for triaging our patients to get onto MDT. At the moment, as I said, it's an electronic standardized performer, which gets put onto Microsoft Teams, triaged from there, and then added to MDT. So obviously you're talking about triage of information. So information then needs to be put into Microsoft Teams. It then needs to come out of there and go into Somerset, then go onto our EPR, and lots of room for error in there. So we're looking at a system where it's actually will communicate automatically with our EPR and with Somerset. So that's an ongoing digital piece of work. You'd be pleased to know I'm not involved in that with my IT skills. We then went on to look at some diagnostic delays and making sure we had everything that we needed within to make the MDT the best discussion it could be based on the information we have. Doing a real focus piece of work around that at the moment. All these work streams are ongoing rather than come to fruition yet. We've looked at how we present cases, so different people present differently, and that's absolutely fine, but we need to be making sure that there's some uniformity there. So we're working on that on an individual basis. And then a separate piece of work on MDT engagement and attendance. As I alluded to before, our team has grown. And what we've realised is there's no one person or one team coordinating who's going to attend MDT. We automatically know who's going to be chair and who's going to be scribe, but not necessarily knowing who else is going to be in the room to have those real fruitful discussions that actually enable you to come out with an MDT outcome. So we're focusing on that a little bit at the moment. So that's going to be, I potentially perceive, a quick win because it doesn't need perhaps a digital solution for that. We can, there's some simple ways we can do that. And then we looked more at communication. So we're getting our MDT outcomes out to our cancer units, usually the same day, but that's a big email push. And if one person is off, it's slow. So we're looking to see whether we can do something digitally for that, really. When you see it written down, you just think, wow, such an awful lot of work going on. And until we've written it down, we didn't realise how much we're actually doing at once and how many plates we're actually spinning. So our work is ongoing, and agree with the comment that was made earlier. It'd be lovely to see in 12 months' time if we can feedback where we're up to and those things that have come to fruition, really. So that's where we're up to as our organisation. Apologies for the background noise. I'm in a shared office. And that's it from me.
Thank
you, Dawn. Any questions?
Really helpful. Yeah, any questions for Dawn? Fabulous. Thanks, really helpful. Thanks, Dawn, and appreciate you just jumping on that really quickly. We have mentioned in the chat, all the poster presentations are up on our Futures platform. We'll share the links at the end. We'll include Dawn's and Liverpool Women's when they've produced theirs, and also up there will be Medway's as well if you want to go and have a look at Medway's who haven't been able to make it today. But thank you to Amy for going chasing around to the offices to try and find somebody around. So thank you for that. So all the presentations are up there. Just a huge thank you for me. I think there's some fascinating, brilliant work that you've been involved in, and I think Dawn touched on it there. Until you write it down, sometimes you don't realise actually how much you have done in quite a short space of time from a change and improvement perspective, and the journey that you feel like you've been on over the last few months. So thank you so much for all the work that you put in and producing the posters to be able to share with people. I think it's really valuable, and giving people other opportunity to see what you've been doing as well, and to learn from each other. So thank you very much for that. I'm going to hand over to Matt for a bit. And he's going to lead us through a little bit of work around the programme evaluation.
Thanks, Nick. And yeah, I just echo what you said, really. That was it was really great to see all the changes that have been made. I know in some areas still some work to do, but yeah, really pleasing. So you guys basically, it's all right, Christy, you can move on. You guys basically were the guinea pigs. This is obviously the first time we've run something like this, the joint sort of process between ourselves and the in the elective improvement support team and the cancer the national team. So we're really keen to hear from you about how it's been and the things we could do better in the future. We do well, hopefully, when we do this with other people. So we know that when we generally ask for feedback after things, we never get any responses. So we're going to force you to do it now, basically. So if we're going to give everybody till maybe past, so there should be a link going into the chat. If you've got a mobile phone, you want to put it on, use the QR code on the screen, you're welcome to do that. But basically, we just want to get your feedback on the program. As I say, the things that you've enjoyed, the things that you think it'd be great if it was done different in the future. Any things that you found unclear or unhelpful would be really good. We really want the honest feedback so we can shape this for the future and make it as good as it can be. So if we will give everybody 8 minutes till past. But if you could go on to the forms, it probably won't take every 8 minutes. I think it's relatively short, so any feedback will be gratefully received, and then we'll come back at past to hear a bit more from Nick around some around sustaining challenges. So thank you. I'll leave it there for the time being.
Thank you for that, Matt. That's really helpful to get that those links shared in the evaluation in progress. I think that link is going to be available for another week, I understand. So for those people, I could see Alison going to pop up there and say that for me. So I thought I'd just get that just in case. Thank you for the reminder. And so yeah, for those reflectors, maybe one of them, we spend a bit. That link is available for another week. So if you want to share with other people as well, that'd be really helpful. Any feedback is always appreciated. As Matt said, we want to learn as well, and we want to improve as well. And I think there is possibly another potential action. The challenge to how do we learn more from you guys in another 12 months or so. So if there was another cohort, maybe there's a bit of mentoring process or a bit of a sharing process from you guys as well for the next cohort that comes on board. I want to just spend a short amount of time, not too long, just talking about sustaining improvement. And I think this is very much about the thing that I've heard so far. I think it feels like I'm preaching to the choir a little bit in terms of I think you probably learned a lot of this already. So you may take a little bit away from it, or it may just reinforce what you've already learned. But for me, what I often find is that pretty much I'm mostly confident when I can see improvement work happening. I'm reasonably confident on the level of optimism for success based on how it started. That point of how does it look like it's going? How has it been prepared? How have we prepared the soil essentially to before we start to embed improvement or change in any kind of environment? And I think sustainability comes from that. Sustainable improvement or sustainable change comes from the start rather than at the end point. We sometimes think about, well, how are we now going to sustain this change after we've already introduced the change? And for me, it's what we've done beforehand. And I think the work that you've done so far really reinforces that about how you prepared the soil and had those conversations and learned from that. What we know from many studies now, that the main one was a McKinsey study back in the 80s and has been replicated many times, is that if we want to, the many success factors or any factors that actually influence change. What they found is that over 70% of change efforts, and this study has been replicated many times, over 70% of change efforts completely fail. They have zero effect on what they intended to. Only 25% achieve some level of sustainable change around their objectives, but only 5% achieve complete level of sustainable change over a long period that led to a longer term improvement. And you think about all the effort that goes into improvement and change within our world. And when you recognize the return on investment of that is really quite low, you then start to understand how we go about change is often more important than what the change is in itself. And what the studies have found routinely is that we set unrealistic expectations. There is poor buy-in, poor communications. You talked about communication here a lot today. Has it been explained well enough to me in terms of what's my role, what's my contribution, what's in it for me, what am I going to get out of this? We're all quite altruistic people in healthcare, but actually we often want to find out what's in for me. So getting this right to start off with can lead to sustainable change in the end. Poor utilization of the existing skills. Have we got the right people? We've heard about the real value of MDT coordinators. Are we utilizing those skills as much as we can do, and the time commitment required to do things? Whether that's an unrealistic expectation around short time periods or over long time periods, and the improvement mechanisms themselves about how we go about things. A quote that goes back to the 1940s and is a little bit wordy, which I've translated, is the way we go about change is more important than the change itself, because we can get fixated on the change itself, and our focus becomes about we just need to see a shift in numbers or whatever the metric might be, or whatever the definition of improvement is. But it's more important that how we go about change, that sustainability is more important, because we can create all the great plans, all the amazing project plans and action plans and Gantt charts and all the best preparation in the world. But if we don't understand that next bit, the bit where we move into action and we move into improvement and change, the work that you've done, there'll be an element of preparation for this program as you moved into it. And then what you've done is you've moved into this space where you've started to test out that change, and it's how you continue that in the future. Because if we get ourselves fixed in this idea that there's a start point and an end point, and it's a nice linear journey based on a perceived action plan, then we're going to be kind of disappointed when we start to hit those barriers and those things that didn't go quite right and those things that unexpectedly did go right. And recognizing that it's a bumpy and rocky road, change and improvement, and how do we remain flexible and adaptable in our work and in our change programs to understand that it's a constant learning process and it's a constant experimentation process, that at times we'll get things right and we'll be nice smooth sailing, and other times it won't be going so right. And if we factor that in to start off with, this can result in higher percentage of sustainable change, that things don't fall over and fail as soon as we hit that first dip in the road and we think this isn't working, and we scrap the whole thing. It's being able to respond and reflect, and that's about really understanding the human condition, the human factors in this around it's people that we're dealing with. We're not talking about machines and robots. These are people with emotions and traits and behaviors, and improvement in healthcare, as Marjorie Godfrey talks about here, 20% technical, and it's 80% human. So we can focus on plans and method and programs of work, but actually it comes down to human beings. It's human beings that influence change. And some quotes here that I've drawn out from a really great document that goes back many years now, from the now defunct Institute of Innovation and Improvement, the Improvement Leaders Guide, managing the human dimensions of change. People are not machines. You cannot make others do as they're told, as much as sometimes we think, just do as you're told and it'll all be fine. People just won't respond to that. They may do it for a short period of time, but they don't do it over a long period of time. Nor can we be everywhere to ensure the compliance. We sometimes want that command and control system to get things done. Maybe not us as improvers in this room, but other people may want that command and control. But if that was the case, there just can't be enough of us. There can't be enough of those commanders and controllers are out there to make sure everybody's doing as they're told. But honestly, who would want to work in that kind of environment anyway? You know, we talk about management and leadership. We manage stuff. We manage products and materials and resources. People, we don't manage people. People want to be led. Who wants to come into work every day and be managed? Nobody wants that. So we provide leadership. None of us want to work in this environment. So if we want sustainable change, how do we create that empowerment in individuals that they feel part of the change and they feel able to move forward and contribute to the improvement? This is about what often is described as this improvement habit that we established. A really great book by James Clear, the Atomic Habits. This is about those, not atomic habits as in blowing things up, but micro, tiny, little habits that we just do constantly, all the time, hourly, daily, weekly, monthly, whatever it might be. And the idea here that James Clear talks about is that the goal is really important. We need to understand where we're trying to head to, but don't focus solely on the goal itself. It's the system to get there. It's the system of how we're going to get to the goal. And that is those small, consistent daily habits, those improvement activities, the habits that we establish as improvers to get us to the point where we want to get to. And a little tool and little model that I've found useful so often over the years is genuinely this kind of improvement habit that we work on. And these 4 steps in that process. The first one, that really understand what we're trying to achieve, set the direction, understand what we're trying to achieve, which you've done brilliantly through this process. The next stage is then grasp the current condition. Where are we at in terms of the difference between where we want to be and where are we at? Really being honest and that true reflection on where are we currently at, so we understand the scope in front of us. And then our next stage is not to try and get to the goal, it's to get to our next target state. And I think what I've heard today from most of you today is you're at your next target condition. You recognize there's more work to do, but you've been able to identify what's your next target state that you want to work on. And in between those 2 stages at level 4, you start to test things out. You try things out, like we've heard about. You try different times, you try different membership, you try different patients who are coming to an MDT, and you figure out what's right. Sometimes you'll go a bit too far one way and then you'll have to come back a bit further the other way. But it's those experiments that are really important. And thinking back to the first session we had on the introduction, when we talked about things like the model for improvement, how will you know that improvement has led to a change? And then what are the improvement ideas that you will test out? That's the space to do it that enables you to get to your next target condition. So your next target condition is from this point onwards. So as we hand over to you guys, identifying where do you want to get to next. It may not be the completed picture. We've talked about 12 months time. You may want to be in a position where you're in a better position. Where do you want to be in 3 months time? Where do you want to be in 2 months time? These smaller, breaking down those daily habits, those improvement habits that gets us to that point, that will help us on our journey. And at times, sometimes we bite off more than we can chew. And Adam Grant, I'm a big fan of Adam Grant. If you ever come across any of his books, professor in organizational psychology, he talks about often the biggest obstacle to successful change is human resistance. We've talked about the McKinsey study earlier. It's the understanding from at a human level of the change itself. We may understand the need for the change, but not assuming that everybody else does. So how do we move people on from that? And his thoughts are around you paint that vivid picture. What are we trying to achieve here? Why is this important? Really connect with the emotions of the individual, appeal to their values. What do people hold true in their world? What's their intrinsic motivators? Why do the other people come to work every day? What's their motivations personally and professionally? And then really importantly, how do we shrink that change so it doesn't become overwhelming? Sustainable change will happen as a result of multiple changes rather than one big bang. They don't tend to work very often, these big bangs. So you shrink the change, reduce the resistance, and that enables people to accept and take on board some of the ideas for improvement and essentially chunk it all up, but have a plan to do it all. And that behavioral change element of it, I think, is so key to sustainability. There are many sustainable models and sustainability models and tools you can use, stakeholder mapping, all these kind of things. But actually, just as I've repeated many times, it comes down to a human level of human behavior. And I've found this behavioral change model. It's based on a public health model from a public health, changing behaviors, changing often comes from a smoking cessation environment, but rooted essentially in behavioural change. And this study by Prochaska, De Clementi and Norcross talked about these stages that people have to go through in any kind of change, however small or great it might be. And anybody at any point won't believe there's a need for change. They're in pre-contemplation stage. They won't understand the need to change the MDT. They'll just think it's okay the way it is. Then we may propose or present some data or information or some learning from elsewhere that people start to think about. Maybe there is a need for change, but I'm just contemplating at the moment. Then they've processed that opportunity. They're now starting to move into preparation stage. And actually, you kind of convinced me we could give this a go, but we need to move this into a sort of action phase where I need to feel more comfortable with that, and then into maintenance phase. What Prochaska, De Clementi and Norcross found from this study is that everybody has to go through these stages one at a time. You can't jump from 1 to 3 or 1 to 4. And what we often find with change and improvement is that we're asking people to go from 1 to 4. We've gone through the process to understand the need for change, and the assumption that the person in front of us is just going to accept our word for it without allowing them to go through those stages themselves. So sustainable change comes about as a result of allowing people to go through that journey themselves. And I think you've demonstrated it really well today in terms of those levels of engagement that you've done and how you can continue that on a go forward. Now, some people will move through this journey very quickly. They can go through it in minutes. If you've got that really compelling argument, that great data, that whatever it might be, they might move through quite quickly. Others, maybe a bit more slowly. They may take a bit more convincing. And with any change and with any normal distribution curve, the same applies to innovation and change. You'll have those people that are just willing to get involved with anything. This group here are probably on the left-hand side of this curve because you've wanted to join this program, you've wanted to get involved. Those innovators, those early adopters, those early percentages within any population group, these percentages play out regularly. You've got those early innovators, those early adopters. Then you start to move into those people who will have looked at the work that you've done through this program and have been a bit curious, but have been waiting for you to take the lead on it, and they'll be interested in what you've done next. They're the people that you start to engage with next, share your learning, other MDTs across your organisations that go beyond your own teams. Now you're starting to move into a tipping point where you're starting to influence the late majority, and you start to get those perceived laggards, those people who are a little bit resistant to change. Now, I'm not a huge fan of the term laggards. I prefer the word skeptic, and use those skeptics. Those skeptics will help you. Those of you who are on the left-hand side of the curve, who are a bit excitable, who like a bit of change, who like a bit of enthusiasm, those skeptics will keep you on track a little bit, just to bring you back to, are you sure? And that's a really healthy way to keep a bit of a balance. But what we find is that in the end, the majority of people come on board because we've gone through those, but allow people to go through that journey themselves. To understand the need for change, we can't just with a big sledgehammer beat people into submission. So there's a few thoughts just to wrap up in terms of how people engage. And another person I respect highly, Eli Goldratt, another great book, The Process of Ongoing Improvement. He talks about any improvement is a change, but not every change is an improvement. And I think we've all experienced change in our lives that hasn't resulted in improvement. So in understanding that is really important. Any change is a perceived threat to people's security, particularly in an environment where they feel under threat or they feel pressured. Any level of change it will feel like a threat to their own security. And any threat to security gives rise to that emotional resistance. People aren't doing it to be difficult. They have an emotional response to that. So you can rarely overcome emotional resistance with logic. So data alone won't overcome emotion. Then you're moving into how do you touch into the human response. The emotional resistance can only become by stronger emotion. If we've got a starting point in terms of a certain position from an emotional perspective, whether it's concern or worry, we have to provide a more compelling reason for that based on emotion rather than pure data. So finally, a few top tips for me to leave you with and to hopefully take away with you, recognizing that I think a lot of you have learned most of this already. Improvement is continuous. It doesn't end. You're on a continual journey with improvement. You're always finding something different out, and being able to see that relying on projects in terms of a start and end point really just gets you going, and then it's how you continue that afterwards. Build, develop, and really practice those improvement habits. It just becomes something that we just do. If you want to learn a new instrument, you have to practice and practice and practice. Anything we want to do differently, we have to continue to practice so it becomes habit forming. Sustainability happens when improvement behavior becomes normalized. It's not something new that we do. It's not something extra we do. Everybody has two jobs, the job that they do and how we improve the job that we do. It just becomes what we do around here, and improvement becomes normalized rather than a special thing that we do over in the corner. And it's really important to remember the normal behavior of the crowd overpowers the desired behavior of the individual. So if we have some resistance, the normalization of this kind of behavior just becomes the normal, and then you have outliers. You have outliers to that normal behavior. So improvement becomes just what we do. Experimentation becomes just what we do. It's not different, it's not unique, it's not a special occurrence that we do maybe either an extremist or if we think we have the time to do it. It just becomes normalized. And taking time to understand what lies beneath that perceived resistance, and I'm really important to stress the word perceived. There is often an observation of resistance, but take the time to understand what lies beneath that resistance. So when we're thinking about sustainable change, we want this to continue for a long time. And the reason why I haven't used sustainability models or tools, because they're fine, they're okay. There's plenty of those around. You can Google that and you can get that yourself. Understanding the human element of this for me is more important. And hopefully what you've picked up on through this program, and I've heard back from today, there's a lot of evidence of that you understand the human element of this and human behavior and the human nature of change. And it isn't just about creating another form and expecting people just to fill that in. There's a how do we bring people on board? So I'm going to leave you with that. We'll share these slides with you after the session, so you can go back and look at some of the nonsense that I've just sort of shared with you, and hopefully that will be helpful some other point. Going to move us on. We have just a reminder of the Menti that we asked early on. That's just to leave that with you. If you haven't already answered that question, what was your key learning? There may be something new from this session today that you wanted to take forward and add to that. That's available to you if you wanted to add to that. Remembering also that the survey and the evaluation is still open for another week. As we sort of wrap these up, any questions, thoughts, observations, any reflections back from anybody they want to share with the group before we depart on this lovely Friday still the morning. Alison, over to you.
I think I'd just like to thank everybody for taking part. It has been a pilot. There has been some teething issues and things that worked better than we expected and things that didn't quite go as planned, but that you've stuck with us. So we really appreciated that. And for the time that people have taken today to fill in the form, if you can keep going with that and share that around your colleagues, the more feedback we get, the better we can make it next time. And also a note that we will be coming out to you guys to see if you want to do the presentations in the sessions and share some of your learning. So I just wanted to say a big thank you.
Thank you, Alison. So if there's nothing else from anybody else, I've just seen something go in the chat. So just have a look and make sure that, thank you, Crystal, for sharing that. Yeah, useful reminder to me, because I always forget. Just to remind again, yeah, the Futures platform is open and all the information is available. The recording from today will also be there. So if you've got colleagues who wanted to you want to share that with, to learn from the other sites that they haven't been able to join you today, then please do share that with them. All the post presentations will be up there. All the past presentations are there from previous sessions. Lots of information there that you can go back to. There'll be elements, I guess, that you'll want to refresh your memory on things that happened months ago. So if there's nothing else, I'm going to sort of move us on, and just on behalf of the team, the team that I'm working with on this program, thank you guys as well. Thank you, Alison, Matt, Dua, Crystal, and Robin, for all your efforts on this work. Thank you very much for allowing me to come and join you for the last few months, and to give me the privilege and the opportunity to sit and listen to all this great work, which is wonderful. Thank you so much for everybody for taking part and all the work. Keep in touch with us if you need anything. You got the email of the team. Just reach out if you need any further support. This is us handing over to you, but not walking away. We're always available if you need us, and we wish you all the best of luck with your improvement work moving forward.
Thank you.
Bye all.
Bye.
Thank you. Bye-bye.
Bye. You're right.
Yeah, it's kicking the last people out.
But that other guy's just obviously switched his thing off and not realised it's over. I've done that before.
To be fair, only having one person left like that is pretty good going. That was very good.